Welcome to the Multiple Sclerosis Virtual Grand Rounds Educational Series. I'm Dr. Alex Rae-Grant, Staff Neurologist at the Mellen Center for Multiple Sclerosis of the Cleveland Clinic. I'm the moderator for this series. It gives me great pleasure to introduce our speaker for today, Dr. Stephen Jones. Dr. Jones is a neuroradiologist at the Cleveland Clinic who does cutting-edge research in neuroimaging, including functional MRI, the localization of epileptic foci, and assessment of whole brain networks. He will talk today about MRI uses in MS. Since the advent of MRI in the early 1980s, our understanding, approach to diagnosis, and recognition of conditions that are not MS have radically changed. Dr. Jones will walk us through the identification of MS lesions based on what we know about the biology of this disease. In addition, he will talk about the many pitfalls of MRI in MS diagnosis and show us a variety of common and rare lesions which might be mistaken for MS. He will make sure we have useful tips for sorting out what constitutes MS and what is probably not MS. He will deal specifically with the vexing issue of nonspecific MRI white matter changes, which increase in frequency with age. His 12 tips for MRI use in MS constitutes a wealth of concrete and clinically pertinent information for all neurologists.
Hello. I'm Stephen Jones. I'm a neuroradiologist at the Cleveland Clinic, and I'm going to present to you a talk on the MRI uses in multiple sclerosis. This is an outline of the talk, and there are going to be two basic parts. The first part is going to be about MRI and some basics of multiple sclerosis. The second part will be 12 different lessons that we're going to learn through a selection of cases. This is what we want to start with. Imagine if we could see the brain with our naked eyes. This is the enemy. This is what multiple sclerosis looks like. This is a 44-year-old male who had 10 years of multiple sclerosis and died from pneumonia. And you can see this diffuse, irregular, granular, confluent white matter lesions every side. If you take a closer look at these lesions, you can see that they are well demarcated. Their locations are confluent around the periventricular regions. They extend to the subcortical regions. And if you had a microscope, you could go all the way from the left-hand side. You can see this luxal stain, where you can see the demyelination occurring. If you go to a higher power, you can see the lesion more evident there as this pallor. And then if you look at the naked eye, you can see the same part of the lesion. But what we seek is a multiple sclerosis lesion that does not require an autopsy specimen. And this is what is provided by MRIs. We seek this correlation between the microscopic pathology and the macroscopic in a living human. This slide reminds us that the MRI signal, the grayscale that we see on our pictures, comes from the magnetic moments that sit on the protons, that sit on the hydrogen atoms, that sit on the water molecules that fill our human tissues. And you can see that these water molecules are dancing around, they're translating, rotating rapidly, vibrating, and it's altogether this rich environment encodes the information about the local environment, and this is what gives us the grayscaleness that we see in our pictures. You can see on this slide is a list of the protocols, the sequences that we use for multiple sclerosis. There are two flare sequences typically, a T2 weighted sequence, proton density, and then typically with contrast there's both a pre and a post. And you can see on this slide, and I'll show you pictures in a second, the different imaging features and the different planes that you'll have here. What's important is that this is a protocol that has been put together many years ago as the best package of different sequences that gives you the capability to make a medical diagnosis helping multiple sclerosis. This package is available on almost all machines, and importantly, it's relatively consistent across all machines. There can be some slight variations of some of the flare sequences, which have proprietary differences between vendors. This next slide shows you now examples of a multiple sclerosis protocol. You can see the classic axial flare with the large lesions that are in the periventricular distribution. You can see the sagittal flare as well. And you can use those two to try and find many lesions and their characteristics, and then as well as the T2 weighted sequence, and then the pre and post contrast T1. So let's think of imaging multiple sclerosis in three domains. There's the spatial domain, where the lesions have their locations, the time domain and how they evolve, and the characteristics, and that's going to depend on which sequence that we use. So we'll start with looking at the location characteristics of multiple sclerosis lesions. The most typical are the classic periventricular white matter distribution, the Dawson's fingers that we all know from medical school. But there are many other places that they can occur, including the brainstem and the cerebellum, and of course the spinal cord. And the spinal cord is particularly important to note that if you're imaging someone for spine lesions and you see one and you have not obtained a brain MRI, that needs to be followed up, because sometimes spine cord lesions are what will drive the patient to the doctor earliest. The next slide shows the sagittal flare, some of these imaging characteristics in the callosal, pericallosal, and the callosal septal area, which is near the midline of the brain, which has a high sensitivity if you can see lesions that are there. And again, you can see that these elongated, they're oriented perpendicular to the ventricles. And that orientation often follows the venous pathways, the perivascular distribution that's in the corpus callosal areas, and this is particularly shown in these high-resolution, high-field images, where you can see, as shown by the black arrows, the signal abnormalities that are surrounding the venules in this periventricular location. The etiology is a little uncertain, probably has to do with some watershed vulnerability to the vessels and parenchyma in this region. And then here we can show off some very recent high-field imaging that beautifully shows these veins from a 7 Tesla now at the Cleveland Clinic. And then on the right-hand side, you can see a 7 Tesla image, but on a patient with multiple sclerosis, and then those yellow arrows show how the lesions form around those venules. So now let's switch to the temporal or timing characteristics. And typically we can break these up into imaging the acute or early phase and then imaging the chronic or late phase. And you can see with this time cartoon how the acute phase is really manifest as the prominence of post-contrast enhancement and then T2 flare hyperintensity, and those both tend to die off with some remnant on the T2 flare. But let's look at some examples. The next example shows you a movie. This was obtained for multiple sclerosis. Over 10 years he was imaged. And you can see in this time-lapse animation how some of the lesions flash into existence on the flare, and they can leave a remnant of hyperintensity long after the enhancement is left. This movie will play through several times, particularly looking, say, in the right occipital temporal parietal region. Early on, there are some examples of a ring-enhancing lesion that appear and then flash away and leave some T2/flare abnormality. The other thing to notice is that you have loss of volume throughout this course, very small, but over about 10 years, there's about nearly 5 to 10% volume loss. The next slide shows you a close-up of one of those lesions that just highlights the characteristics of the image, which flashes in as a contrast ring-enhancing lesion and then leaves as its residue a small flare and lesion that remains there later. Sometimes not all the ring-enhancing lesions do leave a flare remnant. The next slide shows an interesting study that imaged a multiple sclerosis patient every month on the dot for 1 year. You can see how there were many lesions that would come into existence that did not cause symptoms, and then after about a month they would disappear. And some of them would not leave remnant flares, although some do. So we can look at some of the imaging characteristics for the early lesions. As you know, they're going to be hyperintense or bright on T2 and flare and proton density. They often are a little hypointense on T1, and they might have kind of fluffy, ill-defined margins, and most show enhancement. Here are some examples of the early lesions that you can see in the left periventricular frontal lobe, again with ill-defined, fuzzy margins, and you can see some definitive enhancement associated with them, and they're seen quite well on both T2 and flare. Now, if we look at the late lesions, they typically have very well-defined borders, and their T2 and flare quite hyperintense, and now the T1 becomes dark, it becomes hypointense, and there will be no enhancement. And as the disease progresses in these patients, they usually become confluent in the periventricular regions, and of course there's this inexorable slow volume loss. Here are some examples of these later lesions. You can see well-defined margins on the left, and then you can see these so-called black holes on the right in this T1-weighted image. So what is flare? Flare is essentially it's a T2-weighted sequence where free water is suppressed. that is, the CSF becomes black. Very roughly, T2 sequences reflect the squishiness of tissue, how much water or edema there tends to be. An MRI is just an exquisite detector of water. And the brain doesn't have too many mechanisms or reactions to injury, and many of them lead to increased water. And particularly with multiple sclerosis, if you have a loss of the hydrophobic myelin, you have increased water come in, and this is just exquisitely seen on a flare. Having said that, there are many places in the brain that will have normal flare hyperintensity, and it's important to know those and to not call them multiple sclerosis lesions. For example, in the ependymma granularis around the anterior temporal horns, frontal horns, or the cortical spinal tracts around the ventricles, or the zones of terminal myelination. Also, there is a rich array of MRI artifacts that can also cause mimics for multiple sclerosis lesions. And in particular, if you look on the posterior fossa on this next slide, you can see that lesions are better seen on T2 weighted sequences rather than on a flare sequence. Other characteristic regions for multiple sclerosis are in the anterior temporal lobes. There aren't too many diseases that affect those. Catacol is one, and your suspicion for multiple sclerosis can be pretty high if you see them there. Also, MS hits the brainstem and the cerebellum, and sometimes the deep gray lesions. This next slide is an important one to try and assess whether the patient has multiple sclerosis or just nonspecific white matter change that people accumulate as they age. This was a study from the Framingham Heart study group, in which they had 2,012 normal patients, and they did MRIs on their brains, and this is a scatter plot of the total volume of white matter signal abnormality on a log scale. So where it says log of 0, that would be 1 cubic centimeter, 1 cc, total volume of white matter lesions. And you can see that by the time you're in your 70s, you might well have 1 to 10 cc's of white matter abnormalities, and that could be a normal person without multiple sclerosis. Well, you can use the next slide to try and translate with some examples visually how many cc's would you see on someone. And for example, at the top you can see a total of 4 cc's might appear as the flare abnormality on that sequence. Imaging characteristics for multiple sclerosis, it's also important is contrast after gadolinium administration, is that contrast is going to be representing breakdown of the blood-brain barrier, and it typically lasts about 1 month, and it should be very infrequent after 3 months. It's important to know that steroids or immunosuppression can stop enhancement within days, and the enhancement usually starts out solid and then grows radially outward and becomes more ring enhancement. Some of the rings can hit gray matter and becomes incomplete. Magnetization transfer imaging can increase the number of lesions, but this technique is prone to artifacts and variation and is often not clinically used. You can increase the dose. For example, we used to do double dose contrast, and that increases the number of lesions, but it's been found not to be cost-effective or clinically effective. We also note that volume of enhancing lesions is higher in relapsing remitting multiple sclerosis compared to chronic progressive. And then people with advanced disease typically show less enhancement, and they fall into the phase of increased volume loss. This next scatter plot shows a study of the duration of enhancement, and as you can see, most enhancement should stop after about 6 to 8 weeks. And notice that the larger lesions enhance the longest. This next slide shows the rich array of different diseases that can look like multiple sclerosis. And it's not my intention to go into all of them, but just to know that the brain's reaction to insult goes down a common pathway, and they can all look the same. This next slide shows 10 different brains, all with white matter lesions. I'll pause a second and ask you to find what 2 of them are multiple sclerosis. It's the 2 that are on the right, and the lesson here is that many things can look like multiple sclerosis, and it's important to have other clinical information and other clues to try and make that assessment. Finally, we come to this question. Which of these 2 patients uses a cane, patient number 1 or patient number 2? Well, no one can really tell. It's patient number 1 on the left. And the problem here is that MRI is pretty poor at trying to predict on an individual basis the clinical status of a patient. I think this reveals the fact that it's not necessarily the total lesion burden, but its location, the real estate, what part of the brain, what pathways in particular are getting affected by the lesions. So what is the role of MRI in multiple sclerosis? Number one, establish a diagnosis. And the second class is to monitor therapy. For example, are there new lesions? Did they get bigger? Should we keep therapy, stop therapy, or change the therapy? And then a third use is in clinical trials. But the main two uses are establishing a diagnosis and then monitoring therapy. So let's now go to the second part of this talk, which are some perils, pitfalls, and tips in 12 neuroradiology lessons. This is a case of a 44-year-old male transferred for a metastatic workup of a ring-enhancing lesion. You can see an avid ring-enhancing lesion, and there's corresponding flare hyperintensity. The next slide shows further in the brain, there's another enhancing lesion, also with concordant flare hyperintensity. However, the characteristics of this lesion are somewhat different. And you'll notice that the lesion more superiorly was a complete ring. This one shows an incomplete ring. And the next slide shows how this is configured with the green ring representing the enhancement, but notice that where it hits the cortex, as shown by the red lines, there's incomplete. This is an analogy of the enhancement representing perhaps a prairie fire, which is spreading out radially slowly, burning the dry prairie grass. But if it hits a river, that ring of fire no longer progresses, and you'll have an incomplete ring of fire. And that analogy is useful to consider incomplete ring sign and how it's pretty unique to active demyelinating disease such as multiple sclerosis and can distinguish it from tumors and infections. The next slide shows the concept of mass effect. On the lower left, you can see a little section of brain that's going to show you two sulci and an intervening gyrus, sort of in a normal configuration. On the right-hand side shows you a lesion manifest as that blue ovoid, and there are two kinds of effects it can have. On the top, it shows mass effect, where that lesion is pushing the parenchyma around it and narrows and displaces the sulci, and then the medial border is also bowed inward. Contrast that to lesions that are also present, but they have no mass effect. And this is a way that you can separate, perhaps, neoplastic lesions from non-neoplastic. In the same patient, you can look a little further, and you start seeing other lesions that are present, lesions that do not enhance, in fact, that are concordant with T1 hypointensity. So you have in this patient that there's a different set of lesions, some that seem to be enhancing, and others that do not, that seem more chronic. So the lessons that we have here are three. One is the open ring sign, which increases the likelihood for multiple sclerosis by a factor of 5 higher than that for tumor and 17 higher than the abscess. Number two, consider, quote, the company it keeps. That in multiple sclerosis, sometimes you can see lesions of many different time points. And if that patient really had metastatic disease, it's unlikely that there would have been a combination of lesions with such different imaging characteristics. Lastly, lesson number three is keep an eye out for mass effect. In this case, this patient had these lesions, and the larger ones actually didn't show very much mass effect at all. So here's a question. Which of the following is typically not a ring-enhancing mass? GBM, or glioblastoma multiforme, acute multiple sclerosis, cavernous malformation, lymphoma, or metastasis? The answer is cavernous malformation, typically is not a ring-enhancing mass. This next case is a 52-year-old male transferred for biopsy of metastatic disease. On presentation, you can see a well-described flare lesion and its concordant post-GAD enhancement. The patient was scheduled for biopsy and came in for the pre-biopsy imaging, now 14 days later, and you can see that the gadolinium image changed considerably. It's now larger and shows incomplete ring sign. So the lesson here is to use temporal changes whenever possible. There are very few things that will change that quickly in the brain. A tumor will not change that fast. There might be some galloping lymphomas that possibly, but if you see a temporal change over a couple weeks, consider active demyelinating disease. Also look at the margins. You can see with those orange arrows that the margins are very well defined, and there's a very strict concordance to the size of the enhancing component to the flare component. If you had an enhancing lesion, let's say that was infective, that's going to elicit a much larger reaction of brain edema surrounding it, where sometimes tumors are the same way. So again, atypical, and consider multiple sclerosis if you see this well-matched enhancement and surrounding and adjacent corresponding edema. So the lessons: number 4, consider the time development of lesions, and number 5, consider the enhancement margins. Here's the next question. If a ring-enhancing lesion is seen, what is an easy procedure to differentiate between metastasis or active multiple sclerosis? A, review any previous imaging. 2, a short interval follow-up, for example, about 2 weeks. C, no treatment and medium interval follow-up, maybe about 3 months. D, a lumbar puncture. Or E, biopsy. The answer would be a short interval follow-up for about 2 weeks. Might be a very easy way to try and discriminate what sort of a lesion someone might be having. If you see very rapid change, your suspicion for multiple sclerosis should be higher. This next case is a 38-year-old male with headaches. The initial presentation, there was suspicion for metastatic disease, and a biopsy was obtained that was ambiguous, but the question was raised of demyelinating disease, and steroids were started. 4 weeks later, the patient was much improved and re-imaged, and you can see that there's a dramatic change in the brain presentation, and the steroids were stopped. And the patient was forgot about for a little while until they came back 10 weeks later, and you can see that there was marked growth of brain lesions now with a very different character, very solid enhancing and widespread signal abnormality, and the patient was found to have lymphoma. And the lesson here is to beware of the effect of steroids on imaging findings. Steroids can stop the blood-brain barrier and can very rapidly stop that enhancement that you see. Also, look at the distribution of the flare abnormality to the enhancement. It was very disproportionate and should have raised questions early on. This is unlikely to be an inflammatory lesion for multiple sclerosis. So lesson number 6, be aware of steroids on imaging findings. Now, the goals of follow-up imaging in multiple sclerosis, as stated earlier, are to see are there new lesions and would there be any larger lesions. To do that, it's important to put side by side the slices from an earlier image to a new image and then to evaluate that. If you don't line them up carefully, you will be comparing apples to oranges and you may be faked out by new lesions that are actually there. Here's an example that's easy. They're well lined up. You can look at all the sulci and see that they match, and you can see the clear presence of a paraventricular lesion on the right. This next slide is a harder one to see. They're carefully lined up, but if you look closely, you can see that there is in fact a new lesion, and it's there in the left periatrial area, shown by the orange arrow. And if these were not lined up well, you probably would never see that new lesion. To evaluate whether lesions are different, here's a lesson. This shows one MRI from a patient 6 months earlier, and then today during imaging. Are the lesions different? Well, it appears today that it might be actually a little bit larger. But when you put it into the context of the adjacent slices, now look, 6 months ago compared to today, you can see, well, yeah, it might be larger, but it kind of looks different all around. That's about 2 or 3 slices thick. That may lay within those slices at different locations depending on when the patient gets scanned. Look at the cartoon on the right. The blue ball represents a lesion. And you can see that perhaps 6 months ago, the lesion would encompass about 3 slices and maybe pokes just a little bit into the top slice. And every slice sees an average of the amount of blue that's in that slice. About 6 months later, or it could even be the next day, maybe the scanner is going to slice through the lesion slightly differently, and therefore you may have some of the slices look slightly different. And it's not due to the fact that the lesion has changed, it's only due to the way the imaging slices cut through the lesion. So the lessons we've had now, number 7, take the time to carefully line up comparison slices before assessing any change. And number 8, beware of any partial volume effects. Next case is a 60-year-old male with mental status change. And you can see that there are many lesions. They seem to have a distribution that's sort of different for multiple sclerosis. There aren't many around the ventricles at all, and many of them are in a periventricular and deep white matter distribution. And this turned out to be giant cell arteritis. Notice the distribution of deep white matter was much more than the periventricular. This next slide shows a lesion probability map from the literature from multiple sclerosis, which was obtained over about 20 patients. And you can see that in terms of probability, that most of the lesions lie along the periventricular and deep white matter margins, as we suspect, but there is a probability that some lesions can lie in the subcortical regions as well. So this map just helps you to realize that there's a lot of statistics. The preponderance of lesions in multiple sclerosis should be around the ventricles, but you can have some that are outside. Therefore, if you had a patient whose preponderance of lesions were in subcortical areas, you may want to raise question whether it really could be multiple sclerosis. So lesson number 9, consider the distribution of lesions. The next case is a 52-year-old male with non-Hodgkin's lymphoma, status post a stem cell transplant. And here you can see some lesions, and they seem to have a distribution that's more subcortical than periventricular. 3 weeks later, you can see that it's very rapidly changed. It's grown considerably, and there's not much enhancement there. This is classical for PML, progressive multifocal leukoencephalopathy. And the imaging characteristics are going to show this progression, often subcortical. There's not much enhancement. About 5% of the lesions do enhance, and they have a preponderance for the posterior parenchyma. This next slide shows a nice example from the New England Journal of Medicine showing the subtle temporal evolution of PML and how it kind of starts with some cortical signal abnormality and then progresses very rapidly from that. This next slide shows PML on Tysabri. And this is very important to realize that if you have patients on powerful immunosuppressants, one of the goals is to see complications that may come from them. And here you can see this new growth of the subcortical white matter signal abnormality. It's a little bit tumefactive, and this occurs in a different location than the other characteristic lesions, and it is quite different. It shows no enhancement and has a very characteristic rim-like hyperintensity on the DWI sequence. So lesson number 10, consider the immunological status, and again, consider the distribution of lesions. Here's our next question. Which of the following is not an attribute of PML? Being progressive, being multifocal, being a white matter disease, being non-enhancing, or predilection for deep white matter and frontal lobes? The answer is E. That is not a characteristic to be in the deep white matter and in the frontal lobes. This next case. Are these brainstem lesions? You can see on this flare in the posterior fossa, 2 elongated lesions in the pons. No, they're not. This is an MRI artifact. It's very common, pulsation overlay. One trick to finding those is to change the windowing level that you're looking at the image so that you're trying to actually look at the air. And if you do that, you can see subtly these ghosts that go in a left-right distribution. They would go all the way off the screen to the left if possible and all the way to the right. And there's a series of them, and they get overlaid on the image. And if you don't realize that and you're only looking at the brain parenchyma in that appropriate image window, you will see these as a fake out of a lesion. What about this one? Is this a lesion? This is another example of pulsation overlay. And here one trick is rather not to look on the air, but to look at another sequence. Remember, if you have a real lesion typically you should see it on other planes and on other sequences. So the lesson here, number 11, always consider another plane or sequence to suggest assessing artifact. That is, real findings should be seen in more than one image only. The next case is a 53-year-old male for continued follow-up. And you can see that there's a subtle signal abnormality with enhancement in the cortex in the left parietal lobe. And that's in the year 2005. And if you come 6 years later, you can still see it again. It hasn't changed. The lesson here is that not all enhancement is bad. This is an example of a benign capillary telangiectasia. Typically, you'll see those as a small blush of enhancement with no other signal abnormality. What about this cortical enhancement? Is this a vessel? Is it real? No, it's probably real. Here, using the concept that you can see it on both a post-contrast T1 sequence and you see a little cortical lesion on a T2 sequence. This is not going to be a vessel, it's real. So here is a summary of the tips. I won't read through them, but you can read them yourself. And I hope you learned some of the perils and tips for doing MRI imaging in multiple sclerosis. And thank you for joining us on this program.
Thanks, Dr. Jones. Thanks for taking us through the use of MRI in MS, particularly in the early diagnosis and differential diagnosis phase. Key points which are useful to the clinician include how common nonspecific white matter lesions are and how they increase with age in an otherwise normal population. We learned about the open ring sign of MS, which may save a number of patients from an unneeded biopsy. You discussed the cortical component of the disease and how MRI tends to underrepresent this critical part of MS pathology. You also showed how MS lesions usually do not show mass effect, differentiating them from tumors. Thanks for sharing your expertise and radiological acumen with our audience.